hello, my wonderful Myo besties. If you've ever wondered whether or not drugs are impacting your clients, this is the live stream for you. I am Carice Laguerre, your Myo best friend. I'm here every single week bringing you brand new content on the topic of myofunctional therapy. And I want to give you a big welcome. Thank you so much for being with me today. We're going to dive into a lot of pharmaceuticals. I'm very excited about this because I've got to tell you that in like zero of the courses I've ever taken have they like really gone in on this topic. And researching it for the last 2 weeks to get to what we have today has been quite the joyful deep dive. So I'm very excited. I just want to remind you to subscribe. If you're watching this on YouTube, subscribe to my YouTube channel. I go live every single week, but it's kind of sporadic because my schedule is all over the place. I'm in charge of a lot of different things. And so you'll be the first to know if you subscribe when I'm going live, what the topic is, and you get the links directly in your email. So you'll be able to easily access the recordings if you can't join me live. Turn on those notifications so that you get all of that information. Comment, that expands the reach. We are not going to hit excellence in our field at all if we're not sharing all the free information and wonderful information that we can. We are at nearly 60 hours of content that is freely available. Okay. There are some places where you have to pay thousands for 60 hours of content that would just get you introductory into the course, into myofunctional therapy. But here, we are all about free knowledge. And so we're giving and giving freely. I love it. I love being here with you. Like always, throw a comment in the chat, just a hi, hello. That way I know you can see me, you can hear me, and I'm not talking out into the void. Because sometimes I wind up doing that, talking out into the void. All right, guys, I am so interested in this topic because essentially what happened and how we got here, and I don't like that my name is kind of blocking my face. So let me see if I can adjust this just a bit. I'm moving and there we go. Okay. All right. So I was at dinner with some friends. My husband and I have very few friends down here in South Florida, but we have a couple of couples and people that we hang out with. And so we were at dinner and there's one particular topic that came up that was pretty interesting to me. So one of the males in the couples that we were chatting with, I've worked with. I know there's a history of obstructive sleep apnea. His wife is one of my good friends, and we went on a girls' trip one time to Mexico. She brought her CPAP. Like, we were all talking about this topic. So I know that both he and his wife have obstructive sleep apnea. They use CPAPs, like it's really bad for the husband and so forth. And so he's talking to my husband and kind of just talking around the table and telling us, hey, I finally got some stuff figured out. Like, I was struggling a little bit with some different things, and it turns out that it was low testosterone. And so I'm on testosterone replacement. And I start thinking to myself immediately, what? Like, I recently attended a conference, and at that conference, I specifically remember one of the few things, because every time you go to a conference, there's got to be a little bit of a takeaway, guys. So I specifically remember going to a conference and taking away that testosterone replacement treatments are contraindicated in those who have obstructive sleep apnea. Like, the speaker definitely said that and presented the research. So I remember thinking about that, like, oh, wow, I don't know enough about pharmacology when it comes to all of this stuff. But from what I just learned, that doesn't sound right. Like, did you talk to your doctor? Did you tell your doctor that you have obstructive sleep apnea? Or is this a new doctor? Like, what's happening? How did we get here? And so it was very confusing to me. I didn't know how to really address it. I did bring it up, and I gave all the information that I knew. And we even looked up some stuff at the table there because I wanted to present it to him and let him know. And so the research is mixed, but research for everything is literally mixed. But the research is mixed, but for at least the first 6 to 8 weeks, definitively, After you start testosterone replacement therapy, which is medications. You can get it in an injection, you can get it in a cream, there's other ways you can get it. But once you start this prescription medication, often given by a specialist like urologist or sometimes a PA or an NP, it depends where your states are and what the laws are and prescriptions and so forth. But often given by a urologist, once you start this, the first 6 to 8 weeks, your AHI can increase by almost double. So if you were having apnea, you're now having really bad apnea, like the first 6 to 8 weeks. After that, some of the research says it's negligible. So your first 6 to 8 weeks, you could really put yourself in high respiratory distress and it can become a really big problem because that's going to naturally alter your response to these hypoxias and hypercapnia and having the low oxygen, and the high carbon dioxide. It's also going to alter the body distribution of fat. So you'll have more visceral fat, and visceral fat we know is more problematic when it comes to our upper airway because more of that visceral fat will build up in the posterior tongue, blocking off the airway, and back here in the pharyngeal and in the neck region. And that is very detrimental, particularly in men. That's why we look at their neck circumferences, right? We're trying to figure that out. And so the first 6 to 8 weeks really bad. After that, it kind of levels out and you might go back to where you were. So you could have a very dangerous high time. It's kind of debatable. And the medical world and all the stuff that I've been looking into the past 2 weeks is that some places are like absolutely 100% contraindicated. You don't even want to take the risk, particularly if it's moderate to severe obstructive sleep apnea and you're giving them testosterone replacement therapy. Those first 6 to 8 weeks could potentially be lethal for some people. And I don't know that there's enough OMTs that know this. Like if there's enough of us that are really aware of this. Because if I wasn't able to bring that up at that table, I don't know that that doctor would have, or I don't know who would have, because other people are like, it's really not that bad. It's 6 to 8 weeks. After that, it comes down and they'll be fine. And it's really a gamble, I think, with people's lives. And there should be more awareness and, side effects, understand this is a possibility that this could happen. Okay. So ideally as OMTs, what you want to do is you want to make sure you're monitoring for any changes in snoring and daytime sleepiness. So if they have a bed partner, if they don't, you want something like a Snore Lab or some sort of app that is going to be monitoring this and ask them to actively monitor it and see what's going on with their sleep. But any changes in their snoring reported by their bed partner and or reported by an app or some way that you have of monitoring their sleep, their snoring, and then the daytime sleepiness. If it's getting worse in those 6 to 8 weeks, they need to have somebody check in. Okay. So whether it is the doctor that they're working with or somebody else, like make sure you are checking in. So this really enlightened me a lot. And it got me thinking, well, what do I really know? And honestly, what do you really know? Like, what do we collectively understand about pharmacology when it comes to this stuff? Now, what I love about being a dental hygienist is that we learn a lot about pharmacology. We had to take that as one of our courses in our dental hygiene trauma education. And so I think that it's important that we do know some pharmacology and we understand how it impacts the oral cavity. And so there's some things we're very, very aware of, but we really need to continue that when we get into advanced things like oral myofunctional therapy, oral facial myofunctional therapy, oral facial myology, or whatever you're calling it today. When you get into that, super important to understand what's going on with drugs and how they're impacting the body and what could be contraindicated, because you could be the difference in helping to save somebody save somebody's life, and or just reminding people. Now, I have one of my very close friends. It's a pharmacologist. No, it's a pharmacist. What is a pharmacologist? I don't know, maybe that's the thing, but it's pharmacist. It's a pharmacist, and would constantly have to be learning and learning and learning, and that's like all she really does is learn and educate herself, because drugs are changing, side effects are changing, reports are changing, is constantly learning. And that was one thing that I think I started taking up once I understood a couple of weeks ago that, like, this is a topic that we need to discuss. We need to keep learning and learning and learning, because if we don't, we really need to evaluate why we even take a medical history. Sometimes you're taking medical history just for the sake of habit. You take the medical history, like, you just don't understand why. Maybe you're not really looking at it, or they'll tell you they're taking certain medications, but you don't look any of them up, or what are the side effects, or does any of this have any impact on what we're going to do therapeutically. So really, it's important for us to understand why we're doing this. I don't think it's a good use of your time, and time is valuable, to take medical history that you're not going to follow up on to, in some way, shape, or form, see how it's going to impact your therapeutic process, impact your client, and so forth. So just know why you're doing it. I think it's incredibly important, and it saves us all a little bit of time and stress, and it really does up level your patient care, and that's what you want. You want to be a better provider. We want to operate in excellence. So if you're taking a medical history, if you're collecting a list of medications, understand what they're for, how they're being used, and what the impacts are. And so that's what we're going to do today. We're going to deep dive into a lot of that. Okay, because our new reason for taking medical history is now to understand the impact of the drugs in perpetuating any sort of symptoms that they already present with, and or new symptoms, because you want to mitigate any potential barriers to program progression by new symptoms, new changes in the soft tissue that are occurring, and to be able to explain those changes that occur. So sometimes people contact you and they're like, I've been fine my whole life. Like, I've been fine for XYZ, insert amount of years here. Some people will tell me, like, oh, for 32 years, I've been absolutely fine, never had any issues. And then suddenly it feels like everything shifted. And my common explanation for that is that dysfunction compounds over time. But maybe there was a new medication or a new treatment or something that came in and just kind of knocked everything off. Sometimes the antihistamines can knock everything off. So I remember in my early 30s, I was welcomed to New Jersey by my physician, who was my physician for a long time and knew that I'm a Jersey girl. Like, I lived in Jersey my whole life, and was like, welcome to New Jersey, you have allergies. And I'm like, haha, but I'm like 31 or whatever I was at the time. That doesn't make sense for me to just automatically develop them. And then I was on, like, round the clock antihistamines, and that only made things worse. It was once I stopped taking the antihistamines that, surprise, I was able to live in New Jersey without having these allergic reactions. But that's neither here nor there. Where I'm going with that is that these sudden changes, sometimes it's not so sudden, and there's a thing that can explain it. And maybe if you just started a round of antihistamines, you might think that, oh, if everything's fine, but it actually impacts your sleep and your muscular function, your respiratory response. It's impacting you in other ways that you're not thinking of, because when we take medications, we're thinking this is the purpose, and this purpose outweighs whatever list of side effects that may accompany it. And so let's dive in, guys. Let's dive in together. I'm hoping we can finish this in a half hour. Let's see how it goes. But what I want you to do is, if you can, grab a paper and pen. I've actually been debating whether or not I want to put together a little, like, list, or like some small guide that will have all this information in it. So I might do that. And if I do, and you're watching the recording, it'll probably be in the links down below in the description of this video. But for those of you watching live and who have the benefit of getting this information right now, just grab a paper, grab a pen, and something to write down, and just any little takeaway that you can. Even if your first takeaway was this testosterone replacement treatment, like, take something away from this. paper and pen. I'm a big paper and pen person. You don't want to see my desk. It's full of like notes and pens and pencils. There's nothing I love more than a good sharp pencil. So grab something, write with, okay? Here are your common culprits when it comes to OSA and OMT. These are the big things that we're really working with a lot of times. So hypnotics, sedatives, hypnotics that come together like barbiturates, these are issues. They're all going to create different responses from our bodies, and we'll break down many of them in just a short amount of time. Muscle relaxants, particularly for OMT. My father is on muscle relaxants. He's been on them since 2017, so it's been like 8 years now. And like he lives by his muscle relaxants. He's got a lot of other stuff going on, but he lives by his muscle relaxants, and like he needs those things. And I did not realize the impact that they have on general muscle relaxation. And we'll get to that in just a little bit. I'm jumping ahead of myself, but muscle relaxants, particularly with OMT, it's going to kind of negate what you're trying to get in gains. So if your patient is taking things, if your client is taking things, you might not be able to work with them in that same capacity. Hormonal medications such as testosterone replacement and some female replacements. When you mix estrogen and progesterone, you might create a adverse effect that postmenopausal women it's not great for. So it might worsen symptoms or put them at more risk for obstructive sleep apnea. So people who might have gone their whole life not feeling really bad, then suddenly a new medication comes in and we've got issues. So these are some of the common culprits and many of the things that we'll talk about, but most of the medications that we will talk about will fall into one of these four categories. So these are the categories you want to be aware of. Okay. Awesome. Let's talk about benzos, benzodiazepines. Benzos, as we called them in pharmacology class, I don't know, I hope everybody called them that. These are typically central nervous system depressants and sedative hypnotics. So a hypnotic and a sedative combined that typically do reduce upper airway muscle tone and suppresses the arousal response to apnea. So you might not wake up realizing that you have the apnea, thus prolonging the apnea. So we all know an apnea, by definition, is 10 seconds or more of breathing that has stopped, okay? We're not talking about a hypopnea, we're talking about an apnea. So this is now going to take what might be 10 seconds and extend it out. You might have 13, 14, 15 seconds now because you don't have that same response. It's going to delay that response a bit. It may reduce a little bit of the muscle tone as well in obstructive sleep apnea patients, and there are several papers that reference that. Yes, they're old, but these are papers like Christian Guilleminault, who we're all very familiar with. These are papers that are really, really thorough and really do reflect well the issues that a benzo could have on that muscle tone and why that might make you more lethal if you're taking a benzodiazepine. So these will be like your Xanax. A lot of people on Xanax. A lot of people using Xanax to sleep, not understanding that Xanax might actually make your sleep worse. And when we're talking about sedatives, I want everybody to remember that a sedative does not put you into restorative sleep. So when you're taking your Xanax or your Valium or you're taking it to go to sleep, it's not putting you in a restorative sleep. It is kind of just putting you under sedation. So you'll imagine if you were going under for a procedure, for a surgical procedure, you're going under, they put that mask on you, they tell you to do the ABCs or count backwards from 10, and you're gone before you even get to like 8 or 7 or before you get to the letter E. When they put you under that sedation, you're not in a restorative state of sleep. Restorative processes aren't happening. Your brain is not doing all the active work it would do if you were in a REM stage of sleep. You are just sedated. You are just like unconscious. And so these sedatives aren't putting you in that restorative sleep. So you're losing a lot of that anyway. But it also puts you at an increased risk for obstructive sleep apnea. And so you want to be aware. if they are on these things and they're reporting to you sleep disordered breathing, symptoms of such, and they haven't been officially diagnosed with obstructive sleep apnea, that's probably where this is going. And so long term, benzodiazepines, just be very aware. Okay. There are some non-benzo hypnotics like Ambien, Lunesta, Sonata that have very similar effects. Ambien, Xanax. I mean, I've heard that combination a lot in these like younger generations. These are things that people are just taking to manage sleep. And it's not doing what you think it's doing. Okay. So the benzodiazepines, just be very, very aware. Barbiturates, phenobarbital. Barbiturates aren't as common. There's not as many people taking them, but there are people who do take them. And when you take them, just know and be aware that these are the risks and that it can make things worse. So again, just like the testosterone replacement therapy, be very aware of the snoring, the daytime sleepiness. Like if you were feeling more impacted while you are taking them and it's increasing the snoring, you're waking up, you might be gasping for air, a bed partner notices a longer period of apnea and they're concerned, that's probably what's going on. And I'll tell you at the end what we can do about that. Okay. Opioids. Opioids, particularly that are connected to analgesics. So opioids that make you feel good, like morphine, fentanyl, oxycodone, those types of things, a higher rate of sleep disordered breathing in those people who are on it long term. So sometimes it's an addiction. Sometimes they might not tell you that they're on it, but 75 to 85% of them, according to research and like really, really well documented things with a high caseload and case study, they're developing at least mild sleep apnea, and then some of them developing a central sleep apnea when it's a high dosage that they're on for chronic periods of time. Mild obstructive sleep apnea is still a concern, and so you want to be on top of that and understand that if it wasn't mild obstructive sleep apnea when they started, or they've never had a history of poor sleep, and then since they've been taking a certain opioid, now they're on more of that scale of like, oh, okay, we need to send them for testing, and then it comes back with mild sleep apnea, opioids could be a part of the issue. Okay. Very well known to depress the respiration and arousal. And so this is going to have an issue too, because you won't respond to the rising carbon dioxide that's happening. And there you'll fall into that obstructive sleep apnea. You're not going to have that response directly and so forth. Why is that up there? Okay. Codeine. Codeine is very big in the drug world. A lot of people are taking it. A lot of the rappers are just taking it just very mildly. And more than about 12 years ago, the FDA officially put out a warning. So this shouldn't be an issue for a lot of kids. It will be an issue if there are people who are abusing the cough syrups that have the codeine. Okay. But for pediatrics, long been known, codeine after tonsils and adenoids, after those have been removed, do not take. Like avoid, 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 because they will cause additional respiratory depression and it will alter the breathing patterns. Tramadol as well. And so both of those are contraindicated if you're already at a high risk. So when you have tonsils and adenoids removed, you're already a little complicated in your as you're healing in your upper respiratory system. And so having and the addition of tramadol or codeine to help you with your pain management is actually not going to help at all. It's going to make things worse and put you into respiratory distress. It can become very lethal, which is why absolutely 100% contraindicated. You shouldn't see this in children. You might see this if there's older, like in the 20s or so forth, and they may have an issue with codeine or cough syrup medications and being abusive of those types of things. Typically, they're not seeing myofunctional therapists, but you might have a loved one who might have that same issue and is wondering what's going on with their breathing, and perhaps they bring it up to you in that way. And so respiratory distress is very well linked to codeine and tramadol. Sedatives, particularly those that are over the counter, though the risk is low, but because you can get it over the counter, if you've been sick and you're like, oh, I just need to take these and just help me sleep for a week, and you have this flu for a week, and you're taking Tylenol PM, you're taking Benadryl, you're taking things, and you're just trying to get yourself to sleep, these sedatives are going to heighten your sensitivities to apnea, so it can prolong the apnea as well. And so that's going to cause you to have worse apnea throughout that time. Particularly with children, sometimes to put them to bed, you want to give them something that will keep them down longer. So some people might give them Benadryl. Melatonin, you'll be surprised to know, is also something that can have this risk on children. So you're giving them the melatonin, hoping to do a good thing and help them go to sleep. But sometimes it's not going to have that same effect. It can actually make them more sensitive to having these apneas and prolong the apnea. And so that was very interesting in a lot of my reading and research. And if I do put together a guide, it'll have all the links to the research in there too. Give me like a week for that. I probably will do it, but I just have not had the time. But it would be a really valuable thing, and I understand that value, and I would absolutely love to do that for you guys. It was so wonderful for me to go down this rabbit hole. Here's some other considerations that I think most people don't really make. Weight gain. And of course, we know and we understand weight gain, and we tell patients all the time, especially if you're overweight, that yes, this is a contributing factor into your obstructive sleep apnea. You might also be surprised to know that if you're able to manage your obstructive sleep apnea, it might help you with your metabolism, and so you might lose weight too. However, weight gain, as it pertains to this particular conversation with drugs, there are certain antidepressants that are going to cause weight gain. A lot of the anti-seizure medications do often lead to increased appetite, which therefore leads to weight gain. Some of the anti-diabetic medications, insulin therapies, do promote weight gain and fat accumulation. And no, we're not talking about the diabetic treatments that are like the GLP-1s. No, we're talking about some of the other ones, okay? They do promote weight gain. And atypical antipsychotics. So we talked about some antipsychotics, like there might be the barbiturates for that. But atypical antipsychotics like olanzapine, clozapine can cause weight gain and metabolic syndrome. And as the weight increases, most of that winds up being visceral fat. And where is the first place to get a lot of fat deposition? Behind the tongue. Okay, that tongue, it picks up weight, and then you can't get that tongue up and out of the airway, and that makes you more prone to obstructive sleep apnea. Hormonal treatments, androgenic progesterones, or steroid derivatives may impact respiratory response and impact apnea in postmenopausal women who are on hormone replacement therapies. And so this affects the men from the testosterone, and it affects the women if they're on an androgenic progesterone. Okay, and that's typically combined with an estrogen when they're combined together. So separately, estrogen or progesterone, women, we like win in this wonderful category. Separately, if you're on hormone replacement for just one or the other, it can actually help if you have obstructive sleep apnea. It makes things a little bit better. But when it is combined, that's when we have more of a risk. And so that winds up being a consideration that I think we all need to take. Obstructive sleep apnea is a wonderful topic, but we have to consider also that there are some impacts for myofunctional therapy with medications that do impact oral motor function. So some neuroleptics or antipsychotics can cause tardive dyskinesia. And I don't know if anybody's familiar or remembers tardive dyskinesia, but this is like they don't have the ability to control this. So there's a word for that. Oh my God. They have these, it's not a tic, because you can take some of those medications actually for tics, but they don't have any influence of this. This is you guys know what I'm trying to get to, but it just happens. There we go. It's an involuntary muscle disorder that does impact a lot of times the face and the oral facial region. And so you would see things like protrusion of the tongue randomly, lip smacking, puckering, excessive blinking, grimacing, and any sort of like writhing movements. But going back to our OMT impact, we have things like Reglan, Maxilon that are typically used for GERD, and a lot of our clients are coming in with GERD, and so they might be on this, an anti-nausea medication or an antipsychotic, or Haldol, which is a very known medication for Tourette's, or antipsychotic. The possibilities for tardive dyskinesia or the risk factor for it do go up because some of them can cause that as a side effect. Tardive dyskinesia is not something that myofunctional therapy alone can address, and it will cause more of a problem for us to work through our program. So it will cause delay through your program. And so make sure that you are very aware. I don't know, I was going to say, I think a lot of us might see people who are on some of these medications, but I know that I've definitely seen people who are on these medications and have not necessarily known that it could have caused tardive dyskinesia. And there may have been some things that we're trying to work through that maybe I was hitting roadblocks I didn't know I was hitting at that point in time. But now I'm more aware, I can manage this more effectively and collaboratively. And so I would probably try to manage this in conjunction with a PT, I think definitely PT with a physical therapist. Muscle relaxants. Muscle relaxants cause generalized muscle relaxation. And a lot of the times, because they're taken orally, you'll have that effect first hit in the oral facial region, and it will impact their ability to engage in myofunctional therapy. And often, even afterwards, like later on in the day, they go to sleep. If they take their muscle relaxants once a day, when they go to sleep, those muscles will remain flaccid. Interestingly enough, my father does have obstructive sleep apnea. He does have a CPAP, and like these things are so wildly in competition with each other. The ability to keep the airway open and the facility of the muscles because of the daily muscle relaxers that have been going on for 8 years, right? So these are the things that it's very enlightening and great to know, because while it seems like his OSA hasn't been effectively managed, there's actually something that's actively fighting against the muscles being able to stay patent on their own. Typical names for these muscle relaxants are they go by their names, at least the ones that I've seen. It's always been baclofen. Baclofen. Oh my God. Why do I struggle saying that? Baclofen, and tizanidine. But cyclobenzaprine and carisoprodol, I'm pretty sure come by those same names too, and don't necessarily have like a main name like metoclopramide for the neuroleptic. More commonly, you'll find that by Reglan, or they might know it as Gimodi. And so they'll have those proper names, whereas some of the muscle relaxants, I've only ever seen them by their actual like generic name. All right, so overall goals: when you see something, say something. If you see it on a medical history, if you go back and you're trying to figure out something because this really lit a bulb over your head and you're like, oh my gosh, I understand that there is something that I have to go back and look into with a particular client, just advise them of the known risk and recommend that they refer back to the prescribing physician. Like I let my friend know, look, here's what we found about testosterone replacement therapy. If you're finding that you are struggling more, which actually wound up being the case, it's like really, really struggling to sleep after starting this, then you need to go back to the prescribing physician and let them know. And that's okay. They can keep taking it. I would never, ever, ever recommend, and I'm not going to tell you to recommend anybody stop taking their medications. They need to continue whatever was prescribed by their physician. We are not medical providers in that sense. We are not going to tell anybody to discontinue any sort of treatment that they are on when it is monitored by a physician. Okay. But monitor the situation the best you can. So there are plenty of apps I don't know if everybody's aware that the FDA has approved the Apple Watch and these things I don't have. I never wear those watches. The Apple Watch and the Android watches for sleep apnea, home sleep testing. So if they have those apps already and they're already monitoring things, like continue to monitor using those apps, using their smartphones. You have a smartphone for a reason. You can use an additional app if you have an Aura ring, like monitor the situation. If you see a medication that I've discussed and you're wondering if it's making an impact, then I want them every single night to be monitoring these things. That way you know what's going on, and that can be the data that is presented to a prescribing physician so that it's not just the patient's word for it, that it's actually, we've been monitoring the situation. So continue to monitor and consider contacting the physician, whether that be by phone, fax, email, or whatever, snail mail, whatever. Just consider contacting the physician. I know it can seem intimidating, but it might be the difference between, a good life or death. Like I said, one of my very close friends is a pharmacist and is constantly having to learn. And I know I have friends that are physicians as well. I have one that's actively in medical school, and it's constant learning. You don't stop the learning. They're in their residency, they continue learning, but there's always more for us to learn. So I never assume that any physician knows everything there is to know. And so there might be something that they are unaware, might be having some contraindication and negatively impacting their patient. And I'm sure many people who do value the work that they do in helping their patients would appreciate a little bit of a heads up that this is exactly what is happening with their patients, and these are the adverse effects that they are meeting. And then they can always be prescribed something else. So there's alternative treatments for absolutely everything, and a lot of recommendations that some of these papers that I looked into did make. And so it's okay. It is okay to make that suggestion that perhaps they go back and have another conversation with their physician or monitor the situation, collect some data, and then present that. But never at any point in time stop taking the medication. Okay? All right. I'm going to start to wrap up here. Feel free to throw something in the chat if you have some questions. But I think it's really important that we end on a positive note. I'm so appreciative of you being here with me today. I think it's really important that you learn something new. And hopefully, you've learned something new with me today, that you try something different. So, take just a little different route, take a different look, take a new perspective, and convince yourself that you have no limits. We are not at the end of our learning. There's so much that we have yet to learn, so much that we have yet to uncover and discover, and so much more excellence to come. It was such an absolute pleasure being here with you today. If you have any questions, please throw them in the chat. I'll be back to answer them later, and we'll get you guys that guide, and I'll start working on it right away. All right, guys, have a fabulous holiday weekend. As of the recording of this, Easter is tomorrow. So if you celebrate, happy Easter. And if you're watching live, happy Easter. If you're not, I wish you nothing but blessings. Thank you for watching. All right, guys. Have a good one. Bye.